So how many of you have ever played soccer? Put your hand up. All right. See. Okay, of those, how many of you were goalies, were goalkeepers? Okay. Oh, good. All right, because we need this. So what I want to do is I want you to watch this. This is 2006 World Cup, Portugal versus England, 0-0 after regulation and extra time. And of course, what they do then is to go into penalty shots, which is just mano a mano, striker versus goalkeeper. So I want you to watch this and see what happens. That's the English goalie.
Penalty to decide, Portugal against England. So now first for Portugal. A perfect penalty. Robertson gets the right way.
He guessed the right way. Those of you who are goalkeepers, what percentage of penalty shots did you ever stop? 25? Anything else? 10? I take it that you weren't a goalkeeper for very long. So it turns out that in professional leagues, it's about 15 to 20%. So it's not very much. Even the most the best goalkeepers, they're only going to get 1 out of 4, 1 out of 5 of these things. So take a look at this one more time.
Robertson guessed the right way.
Okay, Robertson guessed the right way. Now we go to the English. The English get a chance.
Lampard is next. Lampard missed the penalty in the match against Hungary recently.
Isn't this so much more fun than talking about economics? I think so.
Lampard against Ricardo.
Oh, what a shame. What a shame.
Is history about to repeat itself?
Yes, it is, because England will lose yet again. England has never won in a World Cup penalty shootout. So it goes. Okay, this is all interesting, but Dan said I had to talk about economics, so I'm going to talk about economics. So, all right, then of course, I then ask a question. What's the optimal strategy for a goalkeeper during penalty kicks? Anybody? I mean, they can do several things. He can go left, he can go right, he can stay in the middle. Random, that's a good one. I always love random. Now, as it turns out, that there are 5 researchers from Israel who did a study of this. It's amazing what academics will do for a living. And what they did was they videotaped every penalty kick in European, the FIFA and for the World Cup, and looked at that very thing. That is, where did the goalkeeper go and where did the kick go? And they recorded all these. And what they found was that the optimal strategy was to stay in the middle. But it turned out that only 5% of the goalkeepers stayed in the middle. Now, these are premier goalkeepers. Why did 95% of the time did these premier goalkeepers not do the optimal strategy? This makes no sense. It's irrational. So what do you think they did? Any guess? Oh, good. That means you have to read my book. Now, the reason is something that why did they move? Something that these researchers called action bias. That the goalkeepers felt that they had to do something. They had to go left, they had to go right, they had to do something. And why was that? Well, because if all they did was stand there, and 80% of the time the goals went by, it'd be, why did you do that? Why are we paying you? All you did was stand there. So they had so that was partly for that, and also partly for their own esteem. What the researchers did as well was to do a survey of the greatest goalkeepers and said, would you feel worse if you stood there and the goal went by, whether you went left or went right? And they said yes. I mean, if I just stood there and let something happen, that really wouldn't be very helpful to me. So we have that. Very interesting, especially if you like football and all. But what does this have to do with healthcare? Well, I would argue that there's a tendency among physicians, patients, and administrators to do something. If a problem comes up, you have to do it now. We all have that kind of bias. Think about this. If you're a patient and you have bronchitis, or you think you have bronchitis, you've been coughing, you go into the physician's office and you say to her, I want something. I want a prescription, I want an MRI, I want a lab test, I want something. But the physician should know that for bronchitis, 90% of the time, it's viral. There is nothing that you could really do. But the patient doesn't know that. So the patient says, well, I want something. If the physician says, well, no, this really is going to clear up under its own, then what is the patient going to think? Why did I come? Why did I make the appointment, wait a week, then drive all the way here, find parking, come in, wait in the waiting room for a half an hour, then have 45 seconds with you for you to tell me that all I need to do is to go home? What is all that about? So the patients want something. They're demanding something. They're demanding action. Now, the physicians, of course, know that if it's bronchitis, most likely it's viral bronchitis, and there's nothing that you really need to do. But it turns out there was an article recently in JAMA Internal Medicine that noted that 73% of the time that a patient comes in with bronchitis, they're given an antibiotic, when in fact only 1% of the time will that antibiotic be appropriate. So why does the physician do it? The physician certainly knows. He or she went to medical school. Well, part of the answer is it's going to be easier to just give them the antibiotic. That'll take about 2 minutes than to spend 20 minutes trying to explain to them why they shouldn't have it. Especially since if they go home, most likely it's going to take 3 weeks for that bronchitis to resolve itself. And so a physician is going to say, I'll give you something, this will be fine. And now one of the things that he probably will not tell the patient is that if you don't take this, the bronchitis will resolve itself in 3 weeks. If you take this, the bronchitis will resolve itself in 21 days. But that's the problem. I mean, we've got this action bias, and so we've got a system that is built, not in this case, not in part because of reimbursement, in part because of our own biases, built for overutilization of resources. So that's the first thing I want to talk about. Let me tell you the second one, something called the challenge of choice. Over 30 years ago, Barbara McNeil and her colleagues up in Boston did this study. And they did it of 3 different groups. They did it of about 250 middle-aged men with chronic disease. They did the same experiment with 420 radiologists, and they also did it with 491 Stanford MBA students. And here's what they did. They broke up the group into half, so I can sort of do this here. What I want the half of you to do is to look at this first presentation. And here is what the task was, and that is, suppose that you have lung cancer, but it's operable. We can do something about it. Now, there are 2 choices that could be done. The first is we could do surgery. And surgery, and here are the statistics. Of 100 people having surgery, 90 live through the post-operative period, and 68 are alive at the end of the first year, and 34 are alive at the end of 5 years. Or you could have radiation therapy. With radiation therapy, of 100 people having radiation therapy, all live through the therapy period, 77 are alive at the end of the first year, and 22 are alive at the end of 5 years. So group over here, you think about whether you want surgery or radiation therapy. This group over here, you were given the other presentation, and that was, if you had surgery, of 100 people having surgery, 10 die during surgery or the post-operative period, 32 die at the end of the first year, and 66 die by the end of 5 years. Or you can have radiation therapy, in which of 100 people having radiation therapy, none died during the therapy period, 23 died by the end of the first year, and 78 died by the end of 5 years. So you all have picked which one you want. Can somebody tell me the difference between those two presentations? There is no difference. The statistics are the same, except for one really seemingly insignificant difference. And that is that the first presentation was in a survival frame. This is how many people live, whereas presentation 2 is done in a mortality frame. This is how many people will die. But the statistics are the same. Now, good statisticians, or actually, I guess this might be an oxymoron, but a good economist would say there should be no difference between these two, because people ought to be able to see through what's called the frame. They ought to be able to see that these are really the same thing. But that's not what happened. For those who were given presentation 1, 18% said, well, I want radiation therapy. But on the mortality frame, 44% said that they favored radiation therapy. To a regular old mainstream economist, this makes no sense whatsoever. But what's happening? And the argument that behavioral economists and that Barbara McNeil and her colleagues have said is that the framing made a difference. And the framing made a difference pretty dramatically. And you have to sort of ask yourself why. I mean, what's the difference between 90 living versus 10 dying? But I think the really key one is to look at radiation therapy. Under the first one, all live through the therapy process. But under presentation 2, it's none die. A whole variety of experiments have shown that the idea of 0 or free is just enormously powerful. It is really kind of dramatic. And that just framing it in a different way, putting it in a survival frame versus a mortality frame, is kind of problematic. Now, if you talk to physicians, which of course you all do, you know that they have this problem or this issue every single day. Because one of the things that they can do is they know that they can influence which therapy is going to be given just by how they frame the issue. Do they talk about the benefits first or the costs first? If they talk about the benefits first, patients are much more likely to go through the procedure than if they mention the cost first. And of course, a physician has to do one or the other. You can't do both simultaneously. You've got to do either the benefits or the costs. And what this leads to is that, as Daniel Kahneman and Amos Tversky, Kahneman won the Nobel Prize in economics back a decade ago, he said that the selection or the adoption of a decision frame is an ethically significant act. So it's important to realize that when the clinicians are framing an issue for a patient, that's going to be an ethically significant act. Well, of course, marketers and politicians understand the power of framing. They haven't quite figured out the ethically significant act, though. But this is the real kind of challenge of presenting people, patients, physicians, or administrators with choices. Let me do one final thing, then I'll scoot off. And an amazing part of this sort of framing is the issue of defaults. You know, in some cases, you have to opt out. I mean, you have to opt for one presentation or another. And in part, it just seemed kind of arbitrary. One of which is blood donation. And this is kind of an interesting issue. You want people to be blood donors. Well, how do you get them to be blood donors? We have an interesting natural experiment here, and this is reported by Eric Johnson and Daniel Goldstein in Science back about a decade ago. And they looked at 11 countries, and they looked at the percentage of adults who were organ donors. And they found for 4 countries, Denmark, the Netherlands, UK, and Germany, that somewhere between 4 and 27% of the adults were registered as organ donors. But in the other 7 countries, it was that. Almost 100%. And so what's the difference? Now, my geography is not exactly the best, but the last time I looked, Netherlands is really close to Belgium. But the difference is in the default rate, in the organ donor register rate is kind of different. And, oops. In fact, here is a border between the Netherlands and Belgium. And so it's really curious. 27% of the patrons on the left are organ donors, but 100% of those on the right. What could it be? What could the difference be? And the difference is opt-in versus opt-out. In the Netherlands, in order to be an organ donor, you need to register. You need to sign your name, check a box, sign your name, and you are an organ donor. In Belgium, right next to it, it's presumed consent. It's opt-out, which is that you are presumed to be an organ donor unless you check a box and sign your name. Now, mainstream economists say that the only way in which this kind of thing could happen is that if there were high, what we like to call transactions costs. That is, yeah, you're going to be an organ donor, but if you don't want to be, what you have to do is take a day off of work, go to the equivalent of the DMV, sit there for 4 hours, have 4 kinds of ID, and then have to pay a processing fee. And maybe that's why they're so different. But that's not the case here, not the case at all. It's easy to either opt in or opt out of either of these. But setting the default is going to be important. And then you ask yourself, well, why is that? Why does that really work? A couple of hypotheses that have been come up with. One is that the default acts as a social norm. It kind of says, well, this is how we do things here. So in the UK, it's, you know, we aren't really organ donors, but if you'd like to be, that's fine. Whereas in Hungary, it's, we are organ donors. So that's the first thing. The second thing is that one of the things this says is if people have kind of ill-defined preferences, they don't know whether they're going to be an organ donor or not, then this default is going to make a big difference to us, or a big difference to them. It's kind of curious. So of course, I've now talked for about 15, 18 minutes. We've watched some soccer. Then you get the question of, okay, so what? This is all very interesting, sort of, but what does this really have to do with it? Do with things? Well, my argument is that is a couple-fold. One is we have these biases. We respond to frames. We are just incredibly vulnerable to defaults, and we don't know it. We don't recognize it. We have no idea. But if we do recognize that there are biases, we go, well, I'm not biased, but I know that Dan is. That he definitely, he's going to be subject to these things. But I mean, I know the difference between that. And the challenge, though, is that all of these things, the defaults, the frames, and the action and the biases, are going to lead to overutilization of resources for the most part. Now, there are some cases in which it will lead to underutilization. Let me give you one example, and that is organ donation. There are currently 100,000 patients on the waiting list for a liver transplant, kidney, heart, lung transplant. There's a big debate about how do we reduce the length of that queue. Well, there are some economists, some just right across the street at the University of Chicago Graduate School of Business, like Gary Becker, who won the Nobel Prize. He said, this is easy. You just raise the price. You pay people to donate their organs. And if you pay people, you know, the price goes from $0 to $10,000, there are going to be more people who are going to be willing to give their kidneys. So let's do it that way. I don't know. There's not a whole good thing about that. But notice what would happen if we went from an opt-in system to an opt-out system, which I don't think a lot of people would feel bad about. I'm not going to make you raise your hand as to whether you're an organ donor or not, but if you were told, you know, everybody's an organ donor, you might as well be. Most people are going to say yes, and I would suspect that within a very short time, that queue of 100,000 is going to go down to 0, and that what also will happen is that now physicians will say, well, I think I have more patients who could be eligible for those kinds of transplants. So in that sense, the healthcare system would end up being better for those people. And we would no longer have 6,500 people dying every year waiting for a transplant. Of course, yes, I know what that's going to do is to increase the cost of healthcare, but even an economist says, 6,500 people dying every year because we don't have enough organ donors versus, okay, it's going to cost us more, I think we would end up in that way. So let me finish up with another idea, and that is choosing wisely. You may have heard about this. This is an initiative from the American Board of Internal Medicine Foundation. What they've done is go to about 50 or 60 medical specialty societies and say, tell us what you think the low-value services are, either low-value tests, procedures, or whatever. And now what they've done is advertise those. And in advertising those, what they're trying to do is to make it more widespread, that what's happening is that, that physicians are supplying and patients are demanding services that they, tell the truth, really don't need. I'm now working with a healthcare system in Maryland to kind of use this. And what we're doing is we're doing a survey of physicians. And what we're asking them and trying to ask them is, why in the world do you, or more likely your physician peers, why do they order these low-value tests? Then what we're also going to do is the same thing with patients. Why do you, or more likely your friends and neighbors, order or demand these low-level tests, low-value tests? And then once we get the results, what we're then going to do is to find what interventions we can do so that the physicians will reduce the number of low-value visits, low-value tests that they order, and try to get patients to do the same sort of thing. What we suspect is that education is not going to be the answer. It's not going to be, they just don't know. It's going to be something else more fundamental, and we're going to have to get at something like action bias or framing or a default to make the difference. So I started out this presentation with saying, well, would you rather hear about Fabio or hear about irrationality in healthcare? Fabio is certainly fun. I certainly enjoyed last night, and I certainly enjoyed the gnocchi. But at the same time, and now we're back to the reality of the real world. And as you think about some of the things that Dan talked about, about where we're going, what we now have in terms of action bias and framing and defaults is really fed by a fee-for-service system. It really is. But when we're turning to a system in which we're now going to be responsible for health of populations, not just the health of people who are walking in the door, then we're really going to have to address and maybe use some of these techniques that we're talking about in behavioral economics. So with that, thank you very much.